Message is, all that seizes is not epilepsy. And I say that because if you've never seen a seizure before, it's pretty bizarre, right? The body's shaking, teeth are clamped down, bloody foam is coming out of their mouths, they're peeing on themselves, they're shaking like crazy, and honestly, if you've never seen it before, you're gonna be looking at them like, I need an old priest and a young priest. Like, this is real exorcist stuff. But typically what happens is they seize, and then they stop, and then their brain kind of reboots, because understand it's their brain is just being out of control. All their cells are firing out of control. So what you see is the motor portion of it. What you don't realize is their brain is just going out of control. So in emergency medicine, we see it all the time, and most of the time it's usually due to people with real epilepsy or some kind of, but there's a differential diagnosis for that. So one morning at 3 a.m., I'm working a shift, on the night shift, and I hear seizure and triage. We've seen it a lot, so my senior resident from the University of Chicago and I sort of get up and like, let's go see if we can help out. So we kind of casually walk out to triage to see what kind of scene there's going on. And the first thing I see is the security guard trying to hold this guy up from behind him with under his arms. And if you ever try to hold a 170-pound man up, and they're not helping you at all, they feel like they're about 300 pounds, right? So this poor guy's struggling to try to hold him up. So my resident's like, let's grab some Ativan and let's go get a cart. And I'm like, but the second thing I see is what looks to be about an 8-month pregnant woman standing next to him, freaking out. So I'm like, oh, let's put this together real quickly. He doesn't have a seizure disorder, does he? Oh, he's got no pulse. Start the clock. This guy dropped dead in triage. So now we're dragging him, thumping his chest all the way to trauma 1 because there's no time. So this is one of the few times where it's not just airway breathing circulation, it's Commonwealth Edison airway breathing circulation. So sure enough, we slap him down on the gurney and put gel pads on him, put quick look paddles on him, and sure enough, he's in VFib. So I light him up. And that is much like you see on TV where they shake, they stop, and they sort of calm down. And now my resident is intubating him because he's out of it, and nurses are putting IVs into him, but I'm looking at the monitor. Because it was VFib first, then he was VTAC for a little while, then he went to a rapid AFib, then he went to SVT, and finally sinus tach. And meanwhile, I'm like, shock, no shock, shock, no shock. I can still smell the burning hair from his chest where we just fried him. And I'm like, do I shock him again? And by the way, you don't shock every rhythm. We hate when we see that on TV. But sure enough, he was in a sinus rhythm. Now, all right, get some amiodarone going, get some heparin going, get an aspirin in this guy, and then stabilize that airway. But what happens when you start perfusing your brain again? You wake up. This guy sat up, ripped the tube out of his mouth, and looked at us like with a bewildered, I just saw, and I know this, but he saw the light. And not only did he see how bright it was, he felt how hot it was. And he looked at us and we said, I don't know if he spoke English. I'm like, hey, how you feeling, sir? He goes, just pain. And he lays back down again. Jump back on him, stick IVs in him, get some medications, and make some phone calls. Meanwhile, get an EKG, call the cardiology fellow who's in-house. Cardiology fellow's in-house within 10 minutes. By then, I'm handing him an EKG that didn't just show ST segment elevations, but it's what we call in the business tombstones. So I'm like, oh, this is an oh my God EKG. So it's a matter of wrapping him up. Let's get him out of here. And sure enough, very in an expeditious fashion, despite the fact there's dark 100, we got him to the cath lab. And it was a true blue save. But there's no time to congratulate yourself after something like that, because by then, you've got a bunch of people that rolled in the door, and 3 MVCs, 2 abdominal pains, 3 kids with fevers, and 2 STIs. And why do they show up at 4 a.m.? So where's the lesson here, right? Did this guy actually have a seizure? He actually did. But why? It's not because he was in withdrawal or he was a drug intoxication or this wasn't a brain tumor. This was my heart stopped and I'm no longer delivering oxygen and glucose to my brain, which is enough insult to make you have a seizure. But don't treat it as a seizure. Treat the underlying problem. If you don't get there quickly, and trust me, at 3:30 in the morning, I'm not at the smart end of my shift. This was a day that there were no ICU beds afterwards. So after his cath, he came back to the ER for recovery. And now we get to actually talk to him because he walked in pale and dead. Where was this guy 14 hours before? He was in his primary care doctor's office complaining of what? Upper abdominal burning sensation. And did he get an EKG? No. Did he get sent home on Pepsid? Yeah. Primary care is tough. And I get they have a different mentality. And I knew the guy. So it was a tough phone call to make at 5 o'clock in the morning to tell him, hey, that guy that you saw earlier, he's okay now. But, cardiologist put a stent in as a widowmaker. And honestly, this guy didn't have a lot of risk factors. He was like 49. He was a heavy smoker, but he had no other past medical conditions that make you think, this might be a heart problem. But there's a different thought process in emergency medicine. I think everybody's dying. So anyone who comes through the door with vague complaints between his shoulder blades and his waistline, it's a heart thing until proven otherwise. Look at it this way. This guy, if he decided, hey, you know what, honey, I don't know what kind of weight there's going to be in the emergency department. Let me go back and put on some sweatpants and some comfortable shoes. So if he did that, on the way in, he would have crashed his car. I would have had 3 patients on my hands. So when he finally came to, after all the hubbub, I said, you know what? This is what I want you to do. When you get discharged from the hospital, and you will get discharged from the hospital, go out yourself, get yourself 2 lottery tickets. One for you and one for me. About 6 months later, I'm in the ER again. Again, it's 3:30 in the morning. And I'm evaluating a 4-month-old kid with fever. And, mom was kind of anxious. She says, I want to make sure that he's doing okay. And, I'm very scared that he's not well. And so we're evaluating the child, and he looks great. And I got a tap on my shoulder. And I turn, I see this guy. He looks at me like, hey, remember me? I'm like, oh, you're my seizure and triage guy. He goes, yeah. I'm like, hey, congratulations, beautiful family. Where's my lottery ticket?